Hello everybody, we are at Paris Vascular Insights and I'm here with carotid tandem lesion expert Ignacio Leal, and he will tell us about carotid tandem lesions. And what I would like to ask you first is, can you define what actually is a tandem carotid lesion?
Absolutely, thank you for the question. Hi everybody, we are having much fun here in Paris enjoying the Congress, and it's really good discussion, good time for discussion and for network. Thank you for the opportunity of this interview. So I don't have to create a definition for carotid tandem lesion because it's already defined in the guidelines, and it's basically when you have a large vessel occlusion in the intracranial vasculature and at the same time a carotid stenosis, mostly in the bifurcation. And so probably the most challenging part of this two lesions in the same patient is that we will have poorer outcomes, we will have more mortality, a higher risk of stroke, and it is finally a challenge for our real practice.
Yes, real challenge. And can you tell us what patients, because there's discussion, should you treat the carotid lesion or only do the cerebral thrombectomy? What patients have an indication for both at the same time?
It is really something we are researching now, and we will probably need more data in the future. But basically, you have to think that most of these patients arrive to the hospital, to the emergency department. Then you have the patient in the hybrid suit, and you perform the first angiogram, and then you find the carotid lesion, and then the large vessel occlusion, which is the indication to bring the patient to the hybrid suit. So the challenge is to decide if the carotid lesion needs treatment or not. And you have to balance between the risk of navigating the lesion, the carotid lesion, without treatment, and the risk of embolization itself if you treat the carotid lesion. And then you have to remember that any kind of intervention in the carotid bifurcation could lead to some kind of hemodynamic instability. And that is really quite challenging in this kind of patients because they are always unstable, and we are always concerned about all the penumbra areas in the brain. So what guidelines say and what we know now is that if we have a significant carotid stenosis, more than 50% to 99%, we have an acute stroke and pure collateralization after mechanical thrombectomy, we should consider a carotid intervention in the extracranial area. You can do it before mechanical thrombectomy or after, which is another decision to make in the acute setting. Again, with pros and cons, but most data suggest that you should treat the intracranial lesion first, and then fix the carotid bifurcation lesion with an stent, with a carotid artery stenting.
And is that because you want to diminish the time of the cerebral occlusion, hoping that there will already be some flow?
Absolutely. Remember, for acute stroke intervention, time is brain. So you need to fix the intracranial lesion as soon as possible because we have neurons suffering, and you need to fix the inflow. And after that, if you fix the intracranial lesion, you will be dealing in the postoperative period with the risk of stroke progression if you don't fix the carotid itself. So first intracranial thrombectomy, and after that carotid artery stenting, in most cases. Okay.
So that would be your way to go.
Absolutely.
First intracerebral and then the extracranial lesion.
Absolutely, and it's again this kind of patient is a great opportunity for multidisciplinary approach, because I am a vascular surgeon, we don't do intracranial work, but we do a lot of carotids. And when we have a patient in the hybrid room, the interventional neuroradiology calls you with this problem, you should
go there,
discuss first, what are we doing?
Yes.
And second, make a decision together. Are you going first? I am going first. Why? And what we are going to do, because finally the patient belongs to everybody, and what is more important, benefits from the multidisciplinary view.
Very interesting. Thank you very much.
Thank you for your question. Thank you and enjoy.